already heard some of the conversation. Some of you may have already seen some of it, if nothing else. But really what this is, so we are, so Mark Becker and I work for Armament-Terry. We're a distributor that actually, and that's not gonna work either. So, this is gonna be really difficult. So, anyways, so this CE presentation is for 2 CE credits provided by Fiedler. So if you have them in your booklet, we'll just go over that real quick too. The very back page is your registration form. You'll fill that out and turn it into me, and then we'll submit it to Fiedler. You'll get 2 Cs for that. And on there it does ask for I think your license number. If you don't have it, don't worry about it. They obviously can find you with your name and location too. So, but if you have it, that'd be great. And then of course an evaluation if you feel you want to. And then the third page is a certificate of attendance. That's for you fill it out, tear it off, save it wherever you save the rest of your certificates. Also for you guys, if you have someone or somewhere that keeps track of it for you, you can take a picture of it and then save it with that digitally that way. So I've heard that's where a lot of people are doing that. So it kind of keeps it with your records. So, all right, well, let's try it this way. So again, I apologize, but we'll go through it pretty quick. So a lot of the things you'll see is with our back table and some of the airline standards changing. So as we go through it, you'll see some of that. And I heard you talk about it. You'd seen it somewhere. So a couple things we'll talk about is just identifying risk of contamination in a perioperative setting. We'll look at different changes for the guidelines that you've seen before. Discussing laminar airflow and how it plays a role, which you're probably very familiar with already. Reviewing the impact of covering the back table and also the history of maybe why we haven't kind of gone through that. And then also identifying situations and techniques for covering it. And that's kind of what we'll do. And if we're going to stick around afterwards, we'll do a little demonstration of that too. So, excuse me. So again, this one is, we're aware of a lot of things of contact contamination in the OR, but really what we're going to look at today is just airborne. So the quality of the air, airborne contamination, things like that. So a couple things that cause contamination, and again, I apologize, you people can see well, but some of the things, again, you're familiar with would be like drapes and surgical attire, could be furniture. There was one study done by at Johns Hopkins. They found on the supply doors there was up to 26% MRSA found on those doors. Again, different times, but they were just through some of their studies. OR doors opening and closing. Any idea what the average OR door open in an hour is? Like how many per hour? How many?
30.
Yeah, good guess, 40. But you would think, on average. So again, that's where some of these things, and all 5 of these are probably also may alert some of the things to you guys of why some policies exist in every hospital, whether it be this one or other ones you've been in. Other things, some activity and personnel, so traffic, those kinds of things, and then also any kind of delay or any longer cases. So if you have dual setups, things like that. So other things that can contribute to airborne contamination. This one, again, it'd be important to see up there, but this is just a percentage of contamination over a 4-hour period. This was a study they did in a locked OR in Cincinnati, and I think it's an orthopedic hospital, and they did it locked, so no cases, nothing, and they just did different swabs in 30 minutes, an hour, 2 hours, and 4 hours, and they just went in and swabbed. There was 4% contamination in 30 minutes, all the way up to at a 4-hour mark, there was right about 30% contamination on their back table. So again, that was in a locked OR, so you can only imagine, going back a couple of slides, what traffic, attire, everything, other things like that can be. So just some things to make you aware of. Excuse me. This is just a couple studies that would show you where they came from. But it really what it comes down to is, on this side is surgical site infections. So this slide's pretty important as far as things you might already be aware of, but would be surgical site infections are the most common type of hospital-associated infection. So right now, there's this study and some of these studies put together that there were in 1 in every 20 cases finds a surgical site infection. Like I said, it's the most common type of infection from any kind of surgical patient. It occurs in 5%. And I think there's the part of the study one that showed like anywhere from 2 to 5. So hopefully you guys are closer to 2% than the 5. And then some of the surgical site infections are preventable because it might be some kind of airborne contamination or things like that. So. There you go. So they're just talking about any, and you guys are probably aware of this too, but a surgical site infection is anything that occurs at the surgical site at 30 days from a procedure or 90 days from an implant. So again, very common, unfortunately, but like very preventable in a lot of cases. So some of the reasons why maybe a lot of hospitals and things like that, or ARON takes this real serious, is because of the impact. So some of the impact could be longer hospital stays, could be more likely to enter ICU, unplanned hospital readmission, higher risk of death, and then also a deep economic impact. To speak on that deep economic impact, they say the average readmission of surgical site infection is about $89,000. So you can understand why hospitals take that very serious. This slide, again, for you people up front, is great. This just kind of talks about different things. So direct medical costs, indirect costs, intangible costs like psychological pain, suffering, those kinds of things. But then other ones, indirect, like lost wages. Direct could be your treatments, testing, supplies, those kinds of things. So this is kind of goes what Hannah and a couple other people said is where this presentation comes from too is in 2019. ARON changed their standards. It said now, and I'll read it to you, it says, a sterile drape should be used to cover the sterile field if it will not be immediately used, whether it be procedural delays, sterile field for closures, multiple tables, or periods of increased activity, pre-incision, repositioning, stuff like that. The other bullet point talks about kind of adding to that point is the other quote in the guideline says, the evidence review for this guideline found no evidence to support that the presence of a person directly observing a sterile table during a procedural delay prevents contamination. So just to talk on those two things, so we'll talk about in the next slide too, is with the guidelines saying that you should cover the back table now also says with those guidelines, ARON saying that you don't necessarily have to have somebody in the presence watching for airborne contamination. So I hear, and this is something for hospitals to take into consideration, but you can look at different ways of changing policy or just continue the policies in which you guys already do. So this one goes to the evolution of the ARON, and it was new to me when I learned this presentation. So I find it bless you. I find it beneficial, but prior to and all the way up to 2005, there was no evidence to support covering the back table or not covering the back table as far as ARON's standard. Then from 2006 to 2012, they recommended you don't cover it because they had no ability to remove it in a safe, sterile way. Then 2013 says you may cover it. Now 2018, now starting in 2019, says you should cover it if it's not immediately used or any kind of delay. Because now there is a way of sterilely removing a drape. So when to cover the table with some of the stuff we've talked about. Before transferring the patient into the OR, during delays, any kind of implant procedures, whether it's a dual double setup, clean closures, maybe trauma, C-sectional, vaginal delivery, just different types. So anytime there's, like I said, if there's not being immediately used or in case of a delay. Now, this goes to the second part of that quote a couple slides back about monitoring the table. So as I said, the old way to say you may cover it and then constantly monitor. Well, now says you can cover the sterile field with a sterile drape and then continue to maintain, whether that be signage on the wall, whether it be a personnel in the room, those kinds of things. That's hospital policies are changing and evolving how they want. So there you go. A couple bullets say posting a sign, limiting traffic, or you can obviously still observe directly, as a lot of you are probably already doing. So length of time. This is one that's kind of, there's a lot of studies all over the map. We like to share it with this one. There's multiple ones, anywhere from 4 to 24 hours of covering based on the way that the study that was done with certain drapes. Longer studies use specially engineered manufactured sterile tables. And then of course the length of time, like I said, it could be whether or not your executive team puts to determine the time, can be the standards or like your facilities policy. Again, this one just shows the 3 different researches from the 4 to 24 hours, whether it be a Dalsum study, a Markel, or a Campbell study. So they each did different studies based on the longevity of the time. So now this is where the technique that ARON went to change their standards as far as covering the back table. So this Z-drape technology, again, you can't really see it from way back there up front, you probably can, but it just kind of shows of a sterile way and a sterile technique to remove the drape that still maintains sterility on the table. So something you guys are probably very familiar with, of course, is the air quality in the OR and why it's important. But what we talk about here is because we're talking about back table drapes is, you're talking about the laminar airflow in the room. It could be a steady stream, creating an air curtain, but a lot of times it's in the center of the room and the back table sits where? In the back of the room or the side wall and some places right by an entry door. So just things to talk about in that case, and that's kind of where it's important, but to say it gets neglected is another reason for this presentation. So, other air quality is big HVAC, so you can talk about the humidity and temperature, how very important it is, but also a thing we can't really control in certain parts of the room as well. So, protecting the surgical site goes back to a couple other bullet points we talked about. Whether you're keeping a number of personnel to a minimum, you're draping a sterile field with minimal handling, keeping furniture equipment dusted and clean, keeping door openings to a minimum, and then covering a sterile table when it's not immediately used. Last couple things, just a couple key points we talked about. ARON's guidelines, when and where to cover, the placement of the table in the OR based on like a laminar airflow, whether or not when you're getting ready to use it, if we can move it, you may already do that here, is moving it closer towards the operating site. And then proper covering techniques, and then safeguarding sterile covered tables. Just if you are, or you're curious, or somebody that you know is interested in, ARON does have a resource implementation as far as that you can, if your policy procedures, maybe a roadmap they can use to kind of say, hey, here's how other hospitals and policy, they're getting their policies in place. So, but again, in summary, guys, surgical sites or inspections are costly. You guys are aware of it. If not, I'm sure you were aware of it, but some of this information may be new to you also. And then, we continue, and hospitals continue to find ways to reduce surgical site infections. So, and this bullet just says, covering the sterile field when it's not actively being used may be crucial, minimizing potential air contamination of the sterile field. So, I apologize for quick and brief, but if you have more questions, are there any questions about this presentation? None? I couldn't have done that well, so we'll just keep moving on. So this concludes. If you guys have, this concludes the presentation. If you guys are curious, I did bring a drape that can be used. Some of you may have already seen it. And the only thing that I'll show you, and that's where Mark and I come in. So we work for Armamentarium that distributes a couple products. This is one of them. And then, you want to help me with it? Yeah. So the only thing to know about this drape, so this is, anybody heard of Sterile Z? There you go, there's a couple hands, okay. So yeah, so the Sterile Z or the Sterile Z drape, it comes in 3 different sizes. I'm gonna show you, I might do the XL because it's bigger. So, but all you need to know about is it's applied by one sterile person and it's removed by 2 non-sterile people. Other than that, it's pretty simple. So, all right, let's.
Are we trialing this, or is it put in place now?
We've tried a couple of times before the big shutdown, so hopefully we'll start up again. This is, we've rescheduled now this talk a couple of times, so that's the hope.
All right, so, just so you understand too, and I guess maybe I can open a few of them, but again, somebody will be opening it, so this is the hardest part of the demonstration, but when they open it, so I wouldn't obviously be grabbing it, so a sterile person would be grabbing it, or I've seen a lot of cases, they may open it or dump it on a Mayo stand or something like that. So you're probably cringing that they opened it, but this would already be, let's say it was over here and they dumped it. That was all sterile because it's inside the pack, okay? So fast forward to this person, right? So what you'll see is there's instructions all over. So just real simple step by step. This is the XL drape because the size of the table. We have a regular size one fits a normal table, and then one that fits like a Mayo stand. So again, just step by step. Can everybody see okay, at least what I'm doing here? So you'll see in this drape, it's got right in the middle, just for showing it to you, there is this belt right here where it says Sterile Z is the middle of the drape. So if in this case is what it has arrows and it's real simple. You would just take it to the middle of the table, and again, this table's been dressed, it has instruments on it and stuff like that. We would just set it here. What I recommend is not draping something over the table, because when I start to open it on this side, you'll see it creep up. So once I get here, I leave it there, and then all I do is I just pull it apart. Because again, we're just draping all these, I pull it apart, see how it started to creep. From here, and again, remind, everything here is sterile, right? This drape itself is good for up to 8 hours. So that's what this manufacturer is they're looking at testing it even longer. But in this case, this drape's up good for and maintaining the sterile field underneath there in sterility up to 8 hours. So, they're, trying to think what else. Oh, a couple other things that we hear is, in this case, obviously you can see it's clear, right? So they, like a lot of times as far as being good up to 8 hours, you can see what instruments are already here. If you needed to adjust something, you could. So again, it's been applied by one sterile person. It's good up to 8 hours. The removal process takes 2 non-sterile people. You mind helping me now? Okay. So again, airborne, there's been contamination that's been sitting for, let's say, 3 hours, and then all of a sudden we're ready to use it. Okay. Mark, he comes down this side. So again, him and I are non-sterile. This is all contaminated. This has in here, it's got handles, and it's real simple. It's got handles here. Mark, he'll grab this end right here. I'll grab this end. So what we're doing is we're containing the contamination. Now this is considered sterile on this side. Him and I will just pull apart, and all the contamination goes to the floor. Right. So that perforated edge allows for, when I pull that curtain back, and now this is considered a sterile field because it's been closed. Now to open it this way. So.
You all use the Sterile Z patient drape now when you're doing O-arm cases?
Yes.
Same principle, this is for back tables.
So when you reached over the table and grabbed the curtain, you were non-sterile, correct?
Yes.
Okay.
Yep.
And once you open, everything inside now is sterile.
Right.
It's the same principle as the patient drape. And this should be done now. The AORN says you should cover the back table if you have a drape.